I will talk about the microwave ablation patient selection and follow-up endocrine points of view. You know, the microwave ablation as thermal and the chemical ablation refers to the versatile non-surgical technique which is used to treat the benign thyroid, parathyroid nodules, and sometimes in selected cases, thyroid cancers. You know, it is safe in a safest hand, but if it is done by the non-expert one, it is not free of the complications that it may cause the morbidity, increase the morbidity and mortality. So we'll start with the thyroid ablation. Who is candidate for this kind of the procedure? You know, we have the American Thyroid Association, and we have in the American Thyroid Association, we have the minimum necessary criteria for ablating the thyroid nodule. What is the minimum necessary criteria? We have the indication for doing the thyroid nodule ablation. We have either for the cosmetic or the compressive disturbances due to the dominant nodule. Or we have the autonomously functioning nodules, either causing subclinical or clinical hyperthyroidism. So we have these two indications for doing the ablation in patients with the thyroid nodules. But we should have the benign cytology on FNA or core biopsy. The ultrasound risk stratification should be very low to intermediate, and the patient should have no history or risk factors for the malignancy, and you should tell the patient about this kind of the therapy for the thyroid nodules and the alternatives and the effects and the complications of this therapy. Which nodule can be ablated? As we said, we have the subclinical or clinical hyperthyroidism due to the autonomously functioning nodules, or we have the compression due to the nodule on the aerodigestive or tracheal compression. So the thyroid nodules should be, by ultrasound, should be classified as thyroid 1 or 2 or 3, and nodules with the thyroid 4, while we have the benign cytology, but we should have 2 benign biopsies to determine whether this nodule is the malignant or benign. But you should have 2 benign biopsies, and sometimes you have just single benign biopsy is sufficient for nodules with a very low sonographic suspicion or autonomously functioning nodules. As you know, if you have the autonomously functioning nodule, it decreases the chance of having the malignancy in that nodule. So if you have autonomously functioning nodule and we have one biopsy telling us that this is not a malignancy, it's enough to say this nodules can be ablated by the microwave ablation. Small solitary benign nodules less than 1.5 cm in size are rarely symptomatic and generally do not require any treatment. For the autonomously functioning nodules, a baseline of 10, less than 10 to 12 ml has been suggested to optimize the likelihood of achieving euthyroidism. So the smaller the size, the result will be better, and the patient may get the euthyroidism after the ablation. What about the multinodular goiter? Multinodular goiter better to be treated by the surgery, but sometimes staged ablative procedures for those who are not candidate for the surgery may be done. But if you have the tracheal compression or the compression on the esophagus or retrosternal extension, it is really difficult to be ablated by the microwave, and should be the surgery should be done for this kind of the multinodular goiter. It's very important before ablating the autonomously functioning nodule to be sure which nodule is the functioning. For that one, we should send the patient for the thyroid scintigraphy. If you have the uptake of that nodule, it means that this nodule is hyperfunctioning or functioning, and you should ablate this one. Otherwise, you should not depend on the thyroid function with the nodule. Sometimes the background of the thyroid is the functioning, and the nodule is the cold nodule. So don't depend on the ultrasound or the thyroid function to say this nodule is functioning. You should depend on the scintigraphy. What about so we talked about the autonomously functioning nodules. We talked about the benign nodules causing the compression of the aerodigestive and the tracheal compression also. And we talked about the multinodular goiter. What about the low-risk papillary thyroid microcarcinoma? We have this paper or article, Clinical Effects of Microwave Ablation in the Treatment of Low-Risk Papillary Thyroid Microcarcinoma and Related Histopathological Changes, which was published in 2021. The result was the microablation is safe and effective treatment for low-risk PTMC, and the changes, the histopathological changes after the ablation was fibroblastic proliferation and chronic inflammation, the most common finding. How do you prepare the patient for the thyroid, for the ablation? You should take the informed consent, and you should talk about the benefits and the risks and the alternative management, and you should talk about the radioactive iodine, the surgery, and the follow-up if you are not going to treat these patients with the ablation. To prevent the postoperative hypocalcemia, if you have the vitamin D deficiency, the patient should be replaced with the vitamin D, and calcium sometimes needed to prevent the postoperative hypocalcemia. In case of hyperfunctioning nodules, hyperthyroidism should primarily be controlled with the antithyroid drugs. As you prepare the patient for the surgery, you'll give the antithyroid drugs to make the patient euthyroid, then you'll proceed to the surgery. The same is true for the microwave ablation. You should give the antithyroid medication and making the patient euthyroid, then you'll go to the ablation. Regarding the blood thinners, the anticoagulants, and the antiplatelet, 7 days should be stopped before the procedure, and the warfarin 5 days, and the directed oral anticoagulant 1 to 1.5 days before the procedure. But you should take the risks of the stoppage of the anticoagulant and the antiplatelets with the procedure. Sometimes if you can control, for example, autonomously functioning nodule with the low dose antithyroid medication, better not to stop the anticoagulant or antiplatelet, and to put the patient on a risk of the thrombosis and thromboembolism. The pre-procedural laboratory tests may be necessary in some cases to check coagulation before the ablation. How do you follow up these patients after the ablation? Thyroid function test performed at 1 month, 6 months, 12 months, and every 12 months thereafter. Ultrasound checkup after 3 months, 6 months, and 12 months. Beta blockers can be used. If you have the features of the hyperthyroidism after the ablation, you can use the beta blocker, and you can use the analgesics and antipyretics after the procedure if the patient has the pain, and you should follow up these patients because the hyperthyroidism or the high T3, T4 after the procedure may be due to the distractions of the nodules and making the release of the T3 to the T and T4 to the circulation. So don't give the antithyroid medication after the procedure. Just give beta blocker to subside the symptoms. Resumption of the anticoagulant medication can usually occur on the day of the ablation. As we said, we will give the antithyroid, and if you have the anti-inflammatory, and if you have the patient should be instructed if you have the swellings, the severe pain and fever, and the patient should come back to the to the hospital to see whether there's a complication or not of the ablation. What about the parathyroid ablation? The indication of the thermal ablation, we have the indication for as we have the indication for the parathyroidectomy at the symptomatic patient or the patient have the asymptomatic, but we have the calcium 1 milligram above the upper limits of the normal, and we have the osteoporosis, nephrocalcinosis, renal stone, and the renal impairment. Plus, the patient should refuse the parathyroidectomy or not suitable for the parathyroidectomy. So still the parathyroidectomy and surgical intervention is the first choice for the parathyroid adenoma or primary hyperparathyroidism. But if the patient is not suitable for the parathyroidectomy, you can go to the parathyroid ablation. Yes, so we have this paper, Effectiveness and Safety of the Thermal Ablation in the Treatment of Primary Hyperparathyroidism, which was a multi-center study. It was if you look at here, the technical success rate was 98.3 and the cure rate was 89.9. And so in conclusion, thermal ablation is effective and safe for the primary hyperparathyroidism. These are the pictures of the parathyroid ablation. The follow-up for patients with the primary hyperparathyroidism, you should do the serum PTH, phosphorus, calcium in 2 hours after the procedure, 1 day, 7 days, 1 month, 3 months, 6 months, and then 6 months interval after the ablation. Because sometimes we have we'll do the after 2 hours and 1 day, because sometimes we have the post-procedural hypocalcemia. So to treat the post-procedural hypocalcemia, you should do the checkup early after the procedure. And sometimes you'll do the after 6 months, because sometimes we need a long period of time to have the effect of the parathyroid ablation. Can be used in patients with the severe hyperparathyroidism, secondary hyperparathyroidism, in those who have had renal failure on dialysis. Yes, of course, it can be used, but you should take other measures. You should replace the patient with the calcium. You should give the 1-alpha to the patient, and at the end, you should give the cinacalcet. If you don't have the response and you have nodules, you can ablate by the thermal ablation. So baseline IPTH level is a good predictor of microwave ablation. Efficacy for severe secondary hyperparathyroidism, parathyroidectomy is more effective for severe secondary hyperparathyroidism than microwave ablation. So still, the parathyroid surgery is superior to the microwave ablation if you have, if the patient is candidate or can tolerate the surgery. The pre-procedure, in those who have the secondary hyperparathyroidism, or even in primary hyperparathyroidism, if you have the vitamin D deficiency, should be replaced. And oral calcitriol, 0.5 microgram twice daily for 3 days before this procedure can be given to prevent the marked hypocalcemia. Because after this surgery or ablation, sometimes we have the frank hypocalcemia, especially in hemodialysis patient, because it affects the serum calcium after the procedure. Sometimes even if you have the hypercalcemia, you can give the 2 to 3 grams of the calcium 2 days prior to the procedure to prevent the post-operative or post-procedural hypocalcemia. The follow-up ultrasound examination and the biochemistry, PTH, the calcium level, the phosphate, and the alkaline phosphatase should be measured in the 2 hours, 1 day, 7 days, as we mentioned in the primary hyperparathyroidism. And
Time's
thank
up.
you.
Oh, thank you. It's right on the mark. Barakallah.